Thank you.
Thank you, Marie, and thank you everyone for joining us. I have the pleasure this morning on presenting on supporting women and families of newborns with opioid-related neonatal abstinence syndrome. To give you an overview of the presentation, so the webinar will cover the prevalence of perinatal opioid use and associated factors with opioid use during pregnancy. I will also describe the presentation and management of opioid-related neonatal abstinence syndrome, and finally review interventions and supports for opioid-using women and their families during pregnancy, delivery, and after discharge home, and obviously the role of breastfeeding in NAS. So it's probably not surprising to everyone, but opioid addiction is highly prevalent in the general population, and I tried to put together some Canadian statistics. You hear it frequently in the media about the rising rate of opiate misuse, and here are some actual facts. So we have data, national rates from the Canadian Tobacco, Alcohol, and Drug Survey. This is data that was conducted in 2015 through a telephone survey. So they do this survey every 2 years, and what they found when they compared rates across years from 2013 to 2015, surprisingly they saw a decrease in past-year prescription opiate use to 13%. However, there was a constant rate of reporting of opiate misuse, and that rate has stayed constant, about 2%. When we look provincially, we have data from what's called a CAMH monitor, and a CAMH monitor is one of the longest ongoing addiction surveys of Ontario adults. It's also an Ontario-wide telephone survey. And what their data showed is that past year non-medical use of prescription opiates actually doubled from 2014 to 2015 to reach 4%. And surprisingly, higher rates of opiate misuse was being reported among women than men. So if we look at the population level, we may have about 560,000 Ontarians who are misusing prescription opiates in 2015. So worrisome trend. So then how does this translate into perinatal populations? Unfortunately, we have very little Canadian data about pregnancy and pregnant women using opiates. The only data that was able to put forward is the Canadian Maternity Experiences Survey, which dates back now to, unfortunately, to 2009. And they performed a telephone survey of birth mothers who had a single live birth during the 3 months before the 2006 Canadian census. And these were women who were still living with their infants. And what they found when they called up women is that 7% of women were reporting street drug use 3 months prior to the pregnancy, and this was reduced to 1% once they were aware of their pregnancy. And if we look at 1 to 2% of Ontario pregnancies being exposed, we could have about 3,000 infants that were exposed to opiates in utero. The bigger data surveys are from the U.S. So the National Survey on Drug Use and Health stems from the U.S. They also perform a survey of residents who are 12 years and older. They also exclude individuals who don't have a fixed address. And they look specifically for pregnant women. So their data asked about past 30 days of use among pregnant women. They found that 5% of pregnant women were using illicit drugs, 1 to 2% had non-medical use of prescription opiates, and 0.2% were using heroin. So if you can see sort of similar trends to what's happening in the general population in Canada. I think it's important to also understand the various psychosocial factors that contribute to the risk of opiate misuse and addiction. So when you ask them about how they got into opiate addiction, they will frequently say that they started to cope with family and social problems and stressors. Also, they had to cope with traumatic life events, whether it was a physical or mental health problem, abuse in the household, violence, also with their own feelings of a lack of self-worth. Frequently, these women are influenced by exposure in their families. So when they were growing up, they were observing their parents using drugs, and that became a coping tool for them. So there's frequently reported multi-generational transmission of problematic drug use. And finally, the influence by the substance use of their partners. So many women end up with partners who are also using, and then this also makes it hard for them to stop using even once they're pregnant. So when you look at these psychosocial factors, we realize that women are using their opiates as a way of coping or escaping their life problems. But the more they're using the opiates to escape, the less they use their other management skills. And over time, it becomes just a cycle of abuse where they have to use to cope with their problems and to just feel normal. And this is part of the cycle of dependence. Now, opiate use does not happen in isolation. Pregnant women with opioid use disorders have overlapping issues, including mental health issues, trauma, social stressors. So when we look at the different bubbles there, within substance use itself, most women who are using opiates are not just using opiates. There's polysubstance use, so they're using several substances together. Frequently with opiates, there's also coexisting use of nicotine, so cigarette smoking, alcohol, marijuana, cocaine or benzodiazepines. So when we look at some of the effects later on, we have to think of all of these factors. We also have a whole host of mental health disorders associated with opioid use. So women are more likely to have greater risk of depression. Almost 50% will report a history of childhood sexual abuse or physical violence, and 20 to 30% of these women have anxiety disorders. And these numbers bear out from a Canadian national cohort of pregnant women with opioid use disorders. So we're seeing similar patterns with Canadian women as we are in the general population. And finally, we have the green bubbles, the social stressors. So many women have also coexisting financial and family-related stressors. They don't have supports to help them with their addiction issues, and then also help them later on with rearing their children. So I think when we look at the big picture, we have to realize that the coexisting substance use, mental health, and the social factors all will impact their ability to recover from their addiction, and therefore we need to look at putting supports into place to address all these various issues. So opioid use is has an, I would say, continuum of risk. So it's not isolated to one time period. So when we look at the consequences, there's the perinatal effects, so during pregnancy. Then there's the short-term effects related to delivery and in the neonatal period, which is the first month of life for infants. And then we have to think of the long-term effects, both for mom and baby. Now, the consequences of opioid use are not just due to the direct drug effect. It can also be because of the intoxication and withdrawal patterns. And it can also be secondary to their other associated factors, like their chaotic lifestyles, their concomitant substance use, and poor nutrition. So I think part of the challenges in the literature is how do we label what the effects are of opiates on their own. So let's start with looking at perinatal risks. So we know that maternal opiate use is associated with negative pregnancy or neonatal outcomes because of the repeated cycles of intoxication and withdrawal. So when you have these fluctuations in blood levels, you're more likely to end up with miscarriages and also with premature delivery. The other problem with the fluctuating levels in the blood is that it can also lead to spasms in the vessels and therefore lead to difficulty with growth. So there's frequent reports of intrauterine growth restrictions, so these babies tend to be smaller than they would be otherwise. And then finally, when we look in neonatal time period, we have the morbidity. So we have neonatal withdrawal, and there's also an increased risk of mortality as well in that first month of life, and even reports of sudden infant death syndrome associated with opiate misuse in pregnancy and postpartum. On the newborn, this is one of the greatest, I would say, difficulties of counseling women. So it's important that they know that any infant who's exposed to regular opiate in utero will develop physical dependence. So these infants are not addicted. They will have dependence on the opiates because a small amount gets to them, and that's regardless of the medication the mom is taking, whether it's methadone, buprenorphine, morphine, oxycodone, heroin. A little bit gets to baby, and they will become dependent. So therefore, when the umbilical cord is cut and these babies are delivered, the newborn is at risk of developing withdrawal symptoms. And at that point in time, they're not getting any more opiates, but infants will have neonatal withdrawal. This syndrome is also sometimes called neonatal abstinence syndrome, or NAS, and I'll use the short form throughout the presentation. Now, in the literature, they say neonatal opiate withdrawal can occur in up to or over 90% of infants exposed to opiates in utero, but I think realistically, probably all infants will have some degree of NAS. It's a matter of the severity, and that's one of the challenges we have is in predicting which infants will have such severe withdrawal that they need actually treatment pharmacologically for their withdrawal. So when we look at the actual presentation of NAS, it's a whole host of different symptoms and signs. And these are the classical presentations of a baby who has NAS. They will have what's called central nervous system hyperirritability. So these infants will have a high-pitched cry. They'll be very stiff, so when you move their arms and legs, they will not be very easy to move. They're very shaky, and the shakiness happens even when they're not being disturbed and they're just lying there and sleeping. You can see they're shaking in their sleep even. Some of these infants also have what's called GI dysfunction, so they will refuse to feed. They have feeding difficulties. They will also have loose stools and poor waking. So these babies need a lot of help with their feeding. And finally, they also have what's called metabolic, vasomotor, and respiratory disturbances. So they have recurrent sneezing, yawning, they have temperature instabilities. So it's a whole host of symptoms and signs that presents as NAS. And it's this cluster of symptoms that determines the severity of their NAS. Now, the other thing we need to keep in mind is that we're talking about opioid-related withdrawal. However, there are some other factors that will affect the severity of the NAS presentation. So in women who are also smoking cigarettes, the number of cigarettes smoked 24 hours prior to delivery is more likely to also affect the score that these babies will have and may even lead to longer hospital stay. So it's important then that when we're treating women who are pregnant and using opiates, that we also focus on the polysubstance use, so their cigarette smoking, so to help them to reduce their cigarette smoking if they're not able to achieve abstinence. The other medications we have to be careful with is psychiatric medications. So the use of antidepressants and antipsychotics sometimes also presents as more severe NAS. And this doesn't mean that women should stop their psychiatric medications, but they should be critically evaluated to make sure that they're on the medications that are actually required. Frequently, women will say that they have sort of more self-diagnosed anxiety and depression disorders, and they will automatically stop these medications once they know that they're pregnant. But we have to weigh the benefits and risks for mom who needs treatment for depression and anxiety versus the possibility of worsening NAS. So again, these factors highlight the need to address the complex situation of opioid-using women antenatally and how this relates to postpartum care. I think this is important data to look at because the incidence of NAS has really increased exponentially. And this is data from the Canadian Institute for Health Information. So starting in 2004, this is the first graph that looks over a 5-year time period. And the purple line is the Ontario rates, and the blue line is national rates, and it excludes Quebec. And when you look at the vertical axis, it's the rate of NAS per 1,000 live births. So starting back in 2004, we had rates of about 1.3 births per 1,000 with NAS. When we move forward to 2009, we found that about 3 infants per 1,000 were now having NAS. And unfortunately, in Ontario, we crossed over. So we started in 2009 to actually exceed the national averages. When we look further data from 2011 to 2015, you can see the purple line is still on top. So unfortunately, Ontario, being a higher prescriber of opiates, has also caught up with NAS incidence. So here we have ongoing higher rates in Ontario. In 2011-2012, we have about 5 infants, and by 2015-2016 cycle, we're almost at 6 infants out of 1,000 births having NAS. So that's a significant increase when we're looking from over a 10-year period. So over a decade, we have about 5 to 6-fold increase in NAS rates. So staggering numbers. And why is that important? Well, as I mentioned, has impact on the individual. So we have infants who are now staying longer in the hospital. We have separation of infant and family. So these babies are not always able to room in, so sometimes mom's not always able to be there 24/7 with the infant. When we're looking at the length of stay on average, about 14 days across the country versus the average newborn of 1 to 2 days, it shows you the impact on the family there. You have an infant that's not just staying in the hospital for observation, but sometimes treatment as well. And then system level, we have higher use of scarce resources. We have neonatal beds at a higher percentage being used for NAS. So for example, we can have at times up to 3% of neonatal beds used for treatment of NAS. And in some hospitals, like probably my hospital, St. Joe's, we could have 10 to 20% of our beds being used for NAS. So NAS is important is not just at the individual, but that system level, and that's what we have to think globally. Then moving beyond the neonatal time period, we also have to look at the impact of opioid use on parenting. So we know that the blue bubble, so we have substance use coexisting with physical and mental health, and also social determinants of health. But then we have to think of how all of these factors impact both parenting and child development. And we know that parenting is based on attachment and self-regulation. And we know that these women who are using opiates struggle with these skills. So let's look at attachment. So attachment is defined as the quality of the relationship between the caregiver and the child, leading to lasting psychological connectedness. So in order to have secure attachment, the parent needs to be able to read the infant cues and needs to respond to them consistently, promptly, and in a warm way. So this is what helps the baby then form these brain connections that says, my mother loves me or my parent loves me and I'm looked after. However, when we have infants of opioid-using mothers who are more demanding, maybe because they have NAS and then because they need more sensitive caregiving, but then we have women who may not be able to respond consistently and display the right sensitivity towards the infant cues, this is what leads to insecure attachment. And we also have substance-using women who also have a lack of positive role modeling. They weren't brought up necessarily in households where they were shown what appropriate parenting is about. So because of their own negative childhood experiences, it compounds the ability to form secure attachment with their own children, which leads to poor quality of maternal-infant interactions. Now, secure attachment is what helps the child also develop their own sense of emotional, social, language development. And when we look at these infants in households of opioid-using moms, they're more likely to end up with insecure attachment, disorganized attachment, because of these challenges in developing a secure caregiving environment. When we look at the second aspect, so self-regulation, we know self-regulation is the ability to monitor and control behavior, thoughts, or emotions, and to all of them based on the situation. So if we think of women who are using opiates, these are women who were using because they had to cope with their distress. So they had difficulty controlling how they responded to the emotions that they were feeling for a variety of reasons. And their opioid use didn't help them regulate their emotions, but actually allowed more maladaptive regulation. So it's not surprisingly then when these women have to demonstrate to their infants how you cope with the stressor, and if their coping strategy is to use opiates, then they may not be able to teach their own children what self-regulation is about. So even though self-regulation is sort of something that comes from the inner self, when you have a caregiving environment that doesn't teach you how to use that inner self, it makes it much more difficult for these kids to learn how to self-regulate. And these are the issues that come out later on in life when these kids actually attend school and they become school-age children and they interact with various other external environments. So then to summarize, we know that opioid-using moms and infants are at higher risk of poor quality of mother-child interactions. And this maternal opioid use then is an additional risk factor for these kids who are also exposed to significant other social environmental stressors. And we worry because insecure disorganized attachment and the poor self-regulation may actually lead to these adverse child outcomes such as neglect and safety concerns. Children may also be at high risk of developing depression and anxiety and substance abuse problems themselves. And finally, may also be more likely to lead to foster placement. And what are the developmental outcomes of these substance-exposed children? Now, child development, we have to look at two factors. So it's the result of both the inborn child characteristics, but also from the impact of the environment. And we have to look at antenatal and then postnatal risk factors. So as I mentioned, the antenatal risk factors that we're dealing with is the exposure on the brain development of opiates, the withdrawal effects from NAS, and then we compound that with postnatal risk factors of suboptimal parenting, chaotic lifestyle, and the other host of social problems. So when we're looking at developmental exposure risk, we have to address the interactions between these various factors that relate the in-utero environment to what happens in the postnatal environment. So what does the literature say? Well, it's a bit complicated because the studies that have been evaluated at this point in time have looked at kids mostly up to school age. A few go up to adolescence. They have mixed studies of some who follow kids who are exposed to illicit heroin and then some who follow kids who are exposed to methadone. And there's a lot of inconsistent developmental findings. So when we look at the literature specifically at women who were on methadone in utero with maybe some polysubstance use, is they found no significant impairment in the kids. However, there seemed to be a trend towards poor outcomes in these children. So what they did is they used various scoring tools to assess development, and they saw that these scores were worse in the kids who were methadone exposed. And this was particularly so during the first couple of years of life. Now in the studies, they tried to compare these infants to controls. So kids who come from similar environments. And so when they looked at these kids into the school age range, so going to age 5 and beyond, they found interestingly that these scores on developmental tools were starting to get closer together. And then so the hypothesis is that maybe then it's not just about the methadone exposure, but it's that socioeconomic status of the parents that may be playing a bigger role on developmental outcomes for these children. And so we cannot link the worst outcomes in the first year's life specifically to the methadone exposure. And then another study that was done by a researcher called Ordean, he did adoption studies. So he tried to evaluate what is the environmental risk on these child outcomes. So he took kids who were exposed to heroin in utero, left with moms, raised with moms, and then those who were adopted, and also compared them to kids who were coming from poor backgrounds. So surprisingly, kids who were raised at home did equally poor as those kids of lower socioeconomic status. So they all, as a group, had worse intellectual impairment, verbal performance skills, etc. But the adopted kids did better. They had normal intellectual and learning abilities. However, when they looked at all heroin-exposed kids, whether they were reared at home or they were adopted, they all had higher rates of ADHD. And specifically, highest rates were among those kids raised at home, which leads to the question of how much are these risks long-term related to the drug exposure versus maybe the moms themselves who also had higher rates of ADHD. So I think in the long term, when we look at the literature, we know that cognitive development of these children who are born to mothers with heroin or maybe methadone exposure, this development is mainly influenced by the environment. And this is where we have to really focus on the parenting once these kids go home. So the supports then we look into putting into place for women with opioid use disorders have to range from the spectrum of pregnancy to postpartum. So when we start with pregnancy, we have to include comprehensive care both during antenatal and addiction care, as well as opioid agonist treatment. In the post-delivery, we have to focus on neonatal abstinence syndrome management, and then post-discharge, we have to look at parenting interventions and community support. So let's start with how we can help these women when they're pregnant. So we know when we look at pregnancy and opioid use disorders, it is a window of opportunity. So women have an increased sense of risk when they're pregnant, and they're more likely to access treatment programs. So this is data that is coming from a Massachusetts program where they took women who were pregnant and attended detoxification and followed them for 6 months afterwards and compared them to women who were not pregnant. So what they found is that pregnant women were more likely to access residential treatment programs, more likely to access methadone services, and more likely to go back to detox if they relapsed. So then overall, as a cohort, the women who were pregnant were more likely to access substance abuse treatment in that 6-month period after initial detoxification. And if they were attending detoxification, they were more likely to actually remain in treatment. So this is that opportunity for women who've struggled for a long time with opioid use disorders to finally make a change. When we look at managing opioid use disorders in pregnancy, we have to look at that big picture as I mentioned earlier. So we have these guiding principles. So when we're treating women who are pregnant and using opiates, we have to make sure we provide a safe environment where they feel they're treated with respect and dignity. We have to make sure that they feel that it's a non-judgmental atmosphere, so they feel comfortable disclosing their substance use. And finally, we need to make sure there's effective team communication between various providers, so not just medical team, but also the social team, that everyone's aware of the history. And in doing so, we're then going to be able to reach our aims, is that we want to prevent stigmatization and discrimination, and we want to provide access to the whole treatment services that are required. And this is an approach that is also endorsed by the World Health Organization in their guideline that was published in 2014. They recommend that all healthcare providers who are managing pregnant or postpartum women with substance use disorders, they should offer comprehensive assessment and individualized care. And therefore, this is also in keeping with the NAS guideline from 2016, which also recommends comprehensive care, which should include obstetrical, addiction services, community care, and psychosocial counseling and support. So when we're looking at pregnant women, we do need to make sure that all these bubbles are addressed in some way for these women. So this is the newest terminology for the comprehensive care is also integrated care programs. So when we look at integrated programs, the definition is the comprehensive care, but in one location, so sort of the idea of a one-stop shop model. And we have evidence from a researcher called Kate Milligan, who has been doing research at Ryerson with her partner also in BC, and they did a meta-analysis that demonstrated that women who were attending integrated programs had improved neonatal outcomes. So these infants had higher birth weights, fewer birth complications. The moms also had better outcomes. They had less drug use shown by fewer positive drug screens. They had more prenatal visits, and also they had fewer preterm births. So therefore, integrated care programs are a win-win for both mom and for baby. Now, I wanted to highlight our program from St. Joseph's Health Center. So I'm the medical director of TCUP, and this is our program. So TCUP was launched back in 1996 on a much smaller scale with the idea to reduce barriers to care for pregnant substance-using women and their children. So in those days in Toronto, women had to attend multiple service providers split up across the city, and so that's why all the services were brought together under one umbrella. So TCUP is an integrated care program. We offer antenatal, addiction care, social services, all in one location. We have demonstrated effectiveness of our program in terms of reducing substance use for these moms. We have decreased morbidity for the neonates as well, and we have high rates of discharge of these infants in the care of their moms. And we were able to do that by following some of those guiding principles that I mentioned previously. But I just wanted to highlight one example of a program in Canada, and there's numerous others like St. Joe's. We have the program in BC, there's First Square and Sheway Services, there's programs in Montreal under the Herzl Family Medicine Care Center there. So there are other similar programs across the country, but this is how one way Toronto dealt with the issues that were at hand back in 1996. So the other component of care, and I want to focus on this briefly, is opiate agonist treatment. So part of managing opioid use disorders in pregnancy is to offer either methadone or buprenorphine as the standard of care for opioid use disorders for women who are pregnant. Now, both of these substances are substitutes for both heroin and prescription opiates, and the reason it does is that when you put them on these medications, it relieves withdrawal symptoms, reduces cravings, so blocks the effect of using other opiates. It accumulates in tissues, so when they use it every single day, they just function normally. They're not sedated, they're not euphoric, and they actually maybe can focus on the recovery aspects. Now, there's numerous benefits that have been demonstrated for OAT during pregnancy. So it decreases maternal illicit opioid use, as I mentioned, and withdrawal symptoms and high-risk drug-seeking behaviors. But it also helps improve pregnancy outcomes. So there's documented reduced rates of prematurity, low birth weight, and infant mortality, which are very important. And it also improves maternal health status because hopefully now these mothers are not just seeking addiction care, but also prenatal care. So these kids are more likely to be discharged home in maternal custody, and that's demonstrated through improved social stability as well. Now, my focus here on OAT during pregnancy, but I think really we have to be realistic that these benefits also continue into the postpartum period as these women transition to motherhood and transitioning to caring for an infant. All of these benefits are continuously providing those help for mom even after baby's born. So for those of you who are not familiar, I just wanted to mention a few words about methadone. So methadone is a synthetic opiate. It's exactly in its effects like morphine. It's a drink, as I've pictured there. It's got what's called a full mu agonist effect. So the more methadone women are taking, the more benefit they get. There's no ceiling effect. The average dose is between 60 to 120, and we know from lots of randomized controlled trials that the dosage range of 60 to 120 gives you the most effective reduction in opioid use and retention in care. It's a liquid, so when women go to the pharmacy, they drink this orange mixture, so it's the methadone combined with some orange drink, and the reason for doing that is to prevent injection drug use, and it's well absorbed from the GI tract, and it can last in someone's system anywhere from 24 to 36 hours. So that is the benefit of methadone. It has this long-term effect. Similarly, buprenorphine has also come on the market as of now a decade ago. It has a different pharmacological profile than methadone. It's called a partial mu opiate agonist, so it still has the benefit of reducing withdrawal symptoms and suppressing opiate cravings, but it has that ceiling effect. So above a certain number, there's no additional benefit to be had. In comparison to methadone, buprenorphine is a sublingual tablet, so they have to put it under their tongue, and it can be absorbed in a few minutes. When it's placed under their tongue, it's not well absorbed if they were to swallow it whole, and it's also seen, therefore, to be safe for an overdose, but it does affect retention and care for individuals who may be higher users of opiates, and also those who may be injection drug users may not get the same benefit from buprenorphine, so they may be getting a greater effect if they were on methadone. Similarly, buprenorphine has a long half-life, in some individuals up to 60 hours, and that is the benefit of buprenorphine, is that it has that long-term effect as well. Now, one of the challenges of buprenorphine is that right now in Canada, it's a combination product. So when individuals go to the pharmacy, they're not just getting a buprenorphine product on its own. It's made into a tablet with naloxone. And naloxone is added as a diversion attempt, and you have different formulations available of buprenorphine, and the maximum recommended dose is about 24 milligrams in Canada. The challenge with buprenorphine in comparison to methadone is when you start it in pregnancy, is women have to be in moderate opioid withdrawal, which may also be a little bit controversial in terms of women being worried about having to wait to start buprenorphine, versus in methadone, you don't have that requirement. What about breastfeeding, and what's the effect of taking OAT during lactation? Well, we know breastfeeding has numerous benefits. So it promotes bonding and attachment between mother and infant. Unfortunately, though, breastfeeding rates are very low among methadone-maintained women. So we have about 20 to 60% of women who are actually starting breastfeeding when they're on OAT, and the early cessation rates up to 4 weeks postpartum. And this may be to various barriers. Women frequently say that they will have different advice provided by various healthcare providers. Maybe the physician and the nurse will give her different advice. There's infant feeding problems. These kids actually will have a difficulty latching when they're going through NAS. For some hospitals, there's some separation between baby and mom. There's also maternal feelings of low confidence and guilt, and I frequently hear from moms saying they don't want to compound the problem by breastfeeding while they're using methadone and buprenorphine. And also if they're smoking cigarettes, they're also more leery to start breastfeeding, and they also get inconsistent advice about breastfeeding and cigarette smoking. But what is the harm? So if we really look at the literature for methadone, we know that methadone has been detected in breast milk, but it's in very low concentrations. And so the earlier studies that came out documented that infants who were breastfed were more likely to have lower NAS scores and maybe even lower treatment and shorter length of stay compared to those who were formula-fed or combination-fed. And then some more recent studies also confirmed that trend of reduced severity and duration of NAS in breastfed methadone-exposed infants. Now, to me, I think we need to figure out, is this because of the breast milk exposure to small amounts of methadone, or is it maybe the act of breastfeeding that has greater effect on reducing NAS? Since breastfeeding involves a lot of skin-to-skin, frequent holding, those would be those comfort measures that actually improve NAS. And when we look at the literature on buprenorphine and breastfeeding, we know similarly that the concentration of buprenorphine in breast milk is low, and because when buprenorphine is swallowed, it has what's called a poor bioavailability, these infants actually receive less than 1% of maternal dose of buprenorphine. So there's very little that actually is absorbed by these infants. Now, the literature is a bit conflicted in terms of, is that at all going to be reducing NAS? We have some studies that indicated that 70% of women were breastfeeding on buprenorphine, but 35% of infants still require treatment for NAS, which might imply that maybe there's no difference in NAS treatment based on breastfeeding with buprenorphine. And then there's other studies that actually thought that those infants who were breastfed and buprenorphine exposed had lower treatment rates and shorter length of stay. So I think with buprenorphine being a newer medication on the market, we need some more experience with this medication before we can really definitively say whether it has an impact on reducing NAS. But I think it goes back again to the act of breastfeeding and what's involved in those comfort measures. So what about managing NAS? How can we support women? And I think we have a big role to help families of infants who are going through the process of NAS. In Ontario, and I'm not sure what's been happening across this country, but I can speak to one of the initiatives that was taken on by the Provincial Council for Maternal and Child Health. They convened a task force to look at unifying how NAS was treated across the province. And I was fortunate to be part of this initiative back in 2010. So what we produced were evidence-based guidelines to inform practice in opioid-related NAS because of that variability in management. So the first document that was produced focused on antenatal to postnatal recommendations, and then we underwent a revision in 2016. So the recommendations for the antenatal component were to make sure that providers would educate pregnant women who are using opiates and their partners or families about the risk of neonatal withdrawal, and that this education would happen in advance of delivery so that the women were better prepared for the baby's hospital experience and NAS management. Now, as part of this educational process, there should also be written materials on hospital stay expectations, the role of the parent, and a resource contact list for them. And also being aware that women will need additional support in the postpartum period because it would help them cope better with their feelings of guilt related to seeing the infants having NAS and the extended hospital stay. There's also support we can offer to women when babies are having neonatal care. These babies require longer lengths of stay, and that can be challenging for a lot of these women and their families. So, for example, there's a requirement of 5 days for methadone buprenorphine exposure in utero, and so we have to find ways to support women while the babies are there in the hospital. So we should focus on supporting the mother-baby diet, and this can be done through various ways, through supporting rooming in, through supporting care by parent or parent at bedside. But we know all these infants benefit from supportive interventions, and only a smaller percentage then need pharmacotherapy if their withdrawal doesn't improve. And breastfeeding should be equally supported in these opiate-maintained mothers, of course, in the absence of other contraindications, since it is something that's beneficial for both mom and baby. So what are the supportive measures? So this is where the parents can become involved. So these are the interventions that can be provided by the parents. So they need to learn how to comfort their babies, not just while they're in the hospital setting, but also once they're ready to go home. So, for example, some of the supportive measures include cuddling, gentle handling, skin-to-skin contact, non-nutritive sucking, and all of these measures can help to reduce the NAS severity because it reduces arousals in these babies, it helps them sleep longer, and it helps these babies transition better between the different awake and sleep cycles. We also know one of the other recommendations is for environmental modifications. So these infants, when they're going through NAS, they do better in environments where there's reduced sensory stimulation, so no loud noises, reduced lights, in conjunction with those skin-to-skin contact. Discharge planning is also very important. So we need to help families to make sure that they're connected to a primary healthcare provider who is comfortable following a baby with NAS. And this should happen obviously before discharge home so that mom knows exactly what to do once that baby's home and who their go-to person would be. Every baby who's exposed to opiate agonists or other substances should also be offered ongoing developmental assessments by a clinical expert. And this is important, as I said, because of the debate around the effects of opiate exposure in utero on long-term development. And these moms will also need a lot of support and guidance during transition to motherhood. And this will help them also enhance their bonding with baby, prevent relapses, and also helps to maintain their mental health. Now, child protection is a very frequent reality of lots of women who are using opiates. Now, women who are stable on methadone and buprenorphine, there's no automatic need to have child protection services involved. But when we looked at the Child and Family Services Act, it's a legal obligation if there's a risk of harm for these infants. If there's ongoing addiction issues in the household or domestic violence, then this needs to be reported to CPS. And obviously, this known risk of having child protection involvement sometimes also obviously acts as a barrier for these women to access care. So these are the issues that should be also discussed antenatally to enhance their access to care. And then finally, what can we do for these families once babies goes home? And again, we have to think of the fact that we have these various factors that still affect mother-infant outcomes. So once these babies get discharged home, we still have to encourage women to continue with their substance use treatment programs. They need to remain connected with counseling and pharmacotherapy. So methadone and buprenorphine should not be stopped once these women deliver. They need that help with continued abstinence and relapse prevention. They may also need mental health treatment. We also should put into place parenting programs for these women to help target early mother-child relationship. They also need close monitoring of child development and timely interventions to optimize outcomes for these infants. And finally, they need a social support network that reduces the level of social stressors. So going back to that picture of the cluster of outcome risk, this is continuous even in the postpartum period. So focusing specifically on parenting interventions, the goal is to improve attachment and the quality of the mother-child interactions from the get-go. And the key ways of doing this is by helping mom learn better reflective functioning and better sensitivity to children's needs. And this can be sometimes developed or facilitated by developing therapeutic relationships between mom and the provider. And we have evidence for the effectiveness of attachment-based parenting. And this is one study I wanted to highlight, which incorporated attachment-based parenting to a residential addiction treatment program. So this is a study that was performed in the U.S., and they included 10 home-based sessions delivered by a trained parenting coach for moms and infants between the ages of 1 and 20 months. And not surprisingly, these interventions focused on nurturance, following the child's lead, so responding to child's cues, and reducing frightening caregiving behavior. So there's where you want to have consistency in the response from moms. So the findings showed improved sensitivity, emotional support for parenting behaviors. So these moms also felt they benefited greatly from the parenting interventions as much as did from the addiction treatment. So this is the evidence that the integrated substance use and attachment-based parenting services are effective in improving parenting capacity. And there's several meta-analyses that have looked at what are the elements of effective parenting programs. And these may be hard to deliver at times, but these are the various factors that have been found to be most helpful. So first of all, as I just highlighted, there needs to be both intensive parent education and addiction treatment. They need to be multifaceted. So not just group skills, but also individual home-based case management. That focuses on child development, communication strategies, and then specific parenting techniques. They also need those added supports. So these parents need collaboration across the disciplines and the sectors that supports these families. And also the children then become involved in these interventions when it is safe to do so. And one of the programs provided actually 30 more parenting sessions over 9 months. And when they looked at the literature, that was one of the most successful programs that provided these long-term interventions and not just focusing on 1 month of programming. So then to summarize, opioid use and NAS have been rising in Ontario over the past decade. There's perinatal opioid use, which has a wide range of effects, not just on the pregnancy, but also on the neonates and postpartum into development. There's coexisting opioid use with mental health issues and social stressors, and obviously that impacts recovery and parenting capacity. So therefore, when we look at interventions to support these women and their children, we have to look at the continuing from pregnancy to postpartum. And the best approach is to have these integrated early interventions, not just look at medical care, but addictions care, parenting, social programs, to not just focus on reducing substance use disorders, but also improving parenting behaviors and child outcomes. And I've put together a few resources that you can look at online, and I've also put down our phone numbers. If people have clinical questions, you're always welcome to call or email us with any specific questions that you may have. And I will stop there and take any questions that you may have.
Okay, I can see, Dr. Ordean, there are some questions right now in the chat. One of them is if there's any type of very specific resource on breastfeeding and methadone, buprenorphine, so guidelines for healthcare providers.
There isn't, for respect to breastfeeding and the use of methadone and buprenorphine, there isn't a specific guideline. What we have available is actually from the U.S. There's a guideline on breastfeeding from one of the societies there. I can forward that reference to them, and you can maybe use it in that way. But unfortunately, Canadian guidelines are limited. We have a few resources from various provinces, BC, and unfortunately, those could be of help, but otherwise, there's nothing that's Canadian specific.
Okay, thank you. And there was a question about medication. Which one is more used or is better for the patient, the drink or the pill?
Now, are they referring to methadone and Suboxone? I didn't understand what that meant.
Yes, exactly. Which is better, the drink or pill for the medication?
They're equal. So I would say both of them are equal. So one of the studies that compared the two was called the Mother Study. And what they did in the study is they compared the methadone to the buprenorphine in pregnancy. And what they did is they took the two medications, randomized women to them, and the outcomes were the same. Unfortunately, what they did show is that maybe there's a benefit with Suboxone in terms of reducing the severity of withdrawal. So these kids who are exposed to Suboxone may have less severe NAS. And that's what is encouraging us now to offer Suboxone, so the tablet or the pill form, to pregnant women. Now, logistically in Canada, depending where you practice, access to buprenorphine may be challenging at times, and that is one of the challenges we have in Canada.
Okay. There was a question from Leah and other people. If we can access the written material you discussed, example for the hospital stay expectation, role of parents.
So there's various examples about documents that have that. I can send a couple of the examples that we have available around the information that's provided around NAS for parents. I mean, our hospital has an example of a brochure that we hand out to parents. I think there's one online from one of the Hamilton hospitals. So various hospitals have their own information, but I can always provide an example of the St. Joe's one if people want to look at our hospital specifically and what's included in a brochure like that.
But you send me the links and I can forward them to the participants.
And there was a question on references for the guidelines.
Yes.
If they can just clarify which guidelines, is it the NAS guideline?
Yes, here I think the breastfeeding must be that, yeah. Okay. Yeah, they're typing.
NAS guidelines. So I can forward the PCMCH guideline I was referring to in the presentation. That's actually the link I put in the presentation. If you put that in your browser, you should be able to access the Ontario NAS guideline. There is one from BC as well if you go to the BC Center for Excellence. So it just depends on where you're practicing in the country. Each province, because methadone is a provincial responsibility, various provinces have done their own version of the NAS guideline. But there are two available, the online that you can access easily.
Okay, thank you. So I do not see any more questions right now, so I would like to thank you for this. Yes, sorry.
I saw one there from Christina.
Oh, yeah, the new narcotic of marijuana.
So I used NAS in my presentation because that's the terminology that's actually being used right now in Canada. So I'm always careful with terminology. So when you look at even the newly released Canadian opioid use guidelines from 2018, they did use the term neonatal abstinence syndrome. And so I'm using the terminology as I've seen in recent guidelines. There's also a bit of a trend now to try and use the word neonatal opioid withdrawal because NAS became sort of this catch-all term when it really wasn't intended to serve that purpose. So I don't think officially we've adopted neonatal opioid withdrawal, but that's why I'm always very careful in my terminology.
Thank you. And there was a question, can we access the ABC parenting program?
I can send you I can send you the PDF. I have a PDF of the article that describes the intervention, the ABC program, and then you can contact the researcher directly because they have published this standardized program of what's included in their parenting intervention.
Okay, thank you. So Colleen is asking any new information on marijuana and pregnancy.
At this point in time, there's nothing new on marijuana and pregnancy, and I know BestChart is working on their new revised resource. If you want to comment on that, Marie, when that will be available.
Yes, exactly. So I will send an email to the list servers when the new document on cannabis for parenting will be released, but this one will be updated shortly. How does the home visiting for families that are in teacup, what is the background of those staff who visit?
So we are fortunate that we work with community collaborators. So because of our association with various programs in the City of Toronto, we have the addiction treatment programs like Breaking the Cycle and the Gene Tweet Center who provide our addiction services. And through those programs, for example, some of my patients who are involved with Breaking the Cycle, they will have a home visiting nurse or a home visiting counselor come to their home. Their training is probably at least, I would imagine, at an ECE levels because they focus on child development, they focus on how mom can play with baby based on the descriptions that I have heard. Now, you can always get in touch with Breaking the Cycle and ask their specific backgrounds of the home visiting staff, but I'm sure there's a certain level of training that's required to do that kind of in-house intervention.
Okay, thank you. There's somebody else typing right now.
So I'm happy to send the list of references.
Forwarding, yeah. Yes,
so
perfect, okay.
put references together. People want to look at some of the various guidelines I've mentioned, some of the references on some of the critical articles, including the mother study, which was the comparison of the methadone and buprenorphine in pregnancy. If you want to read some of the literature, I'm more than happy to put together that list of references if people want to do further reading.
Okay. Okay, so I would really like to thank you again for this great presentation and more of the information to come forward for us to read after this event. So thank you again. And
as you can see, my email address is there as well. So if anyone wants to email me directly, if they're shy to ask as a group, you're welcome to do so as well.
Okay, thank you. Thank you, thank you. And excellent presentation. Okay, thank you for everybody to attend. I'll send the link also for the evaluation at the same time after I receive all the information from Dr. Ordean. Have a good day. Bye-bye.
Thank you. Bye-bye.
Bye, thanks.